All right, so we have 5 really interesting presentations today, and I have the pleasure of introducing each one of them. Our first one up is Dr. Meghana Eswarappa. She is currently a third-year nephrology research fellow at University of California, San Francisco, within the Kidney Health Research Collaborative. And her research area focuses on health services research around care delivery for individuals with genetically driven kidney disease. And she'll be talking to us on the association of SGLT2 inhibitor therapy with longitudinal eGFR changes among US veterans with ADPKD. And I'd like to welcome.
My name is Meghana. I'm going to present a project titled Association of SGLT2 Inhibitor Therapy with Longitudinal eGFR Changes Among U.S. Veterans with ADPKD. I have no disclosures, and the objectives for this presentation are to recognize that there are limited therapies available for ADPKD and to compare eGFR slope after SGLT2 inhibitor versus DPP4 inhibitor initiation in ADPKD. So to start off with some background, autosomal dominant polycystic kidney disease is the most common genetic form of kidney disease with an estimated prevalence about 1 in 1,000. And mutations primarily in PKD1 and 2 drive cyst growth, which leads to kidney enlargement and eventual kidney function decline. And cystic kidney disease is the 4th most common cause of ESKD in the United States. But despite this, we have limited treatments available for ADPKD. Right now, the only FDA-approved medication is tolvaptan. So we were interested in the potential use of sodium glucose cotransporter 2 inhibitors in ADPKD. They're a class of drugs that were approved about a decade ago for management of diabetes, but since then have been shown to improve cardiovascular and kidney disease outcomes, but they have not been studied well in ADPKD. So some potential benefits of SGLT2 inhibitor use in ADPKD are that they can lead to reduced glomerular hyperfiltration, which is a risk factor for disease progression. They can induce ketogenesis, which has been shown in animal models to inhibit cyst growth. They can lead to improved glycemic control and weight loss, which is relevant for patients with diabetes and obesity. And of course, patients with ADPKD can have other comorbidities with approved indications for SGLT2 inhibitors. So they could benefit, for example, from reduced cardiovascular risk reduction. On the flip side, SGLT2 inhibitors can lead to an osmotic diuresis, which can increase vasopressin levels, which is known to stimulate cystogenesis. So as you can see, understanding the effects of SGLT2 inhibitors on kidney function is not only relevant towards identifying new potential therapies for ADPKD, but also towards understanding whether it's safe to use in our patients who have other indications for them. So currently the FDA does not recommend SGLT2 inhibitor use in CKD associated with polycystic kidney disease because ADPKD patients have been excluded from the relevant trials. There are a few observational studies, but they are on the smaller side with limited follow-up time. So moving on to methods, we try to partially bridge this gap by conducting a retrospective observational study using electronic health record data from the Veterans Health Administration. And we specifically conducted a target trial emulation to compare the effects of SGLT2 inhibitor versus DPP4 inhibitor initiation on eGFR slope in patients with ADPKD and type 2 diabetes. And target trial emulations are a type of observational study design that are intended to mimic a randomized trial to improve causal inference. And they're useful for cases like this where our population of interest has been underrepresented in trials, but for whom we have observational data on. And the reason we chose a DPP4 inhibitor as a comparator is because it's not known to affect kidney function and because it has a shared indication with SGLT2 inhibitors as an oral diabetic agent. And so this would help limit confounding by treatment indication. So these were our eligibility criteria. We included patients who were at least 18 years old and had an ADPKD ICD-10 code and type 2 diabetes, and initiated an SGLT2 inhibitor or a DPP4 inhibitor between January 1st, 2017 and May 1st, 2023. And we excluded patients if they had type 1 diabetes, no primary care encounter or outpatient eGFR in the year before initiation, if they had pre-existing ESKD, were enrolled in a clinical trial or hospice care, or if they received their prescription by a non-VA provider. Our treatment strategy was to initiate an SGLT2 inhibitor or a DPP4 inhibitor And we used inverse probability of treatment weights to emulate randomization to either one of those treatments at their initiation. And the inverse probability of treatment weights were estimated based off factors that might influence treatment and outcome. That included baseline sociodemographic factors, clinical variables, including other comorbidities or medication use, and facility characteristics. And our outcome measure of interest was the mean eGFR slope per 90 days. And we chose a 90-day interval because we wanted to capture the potential dip in eGFR that is known to occur after SGLT2 inhibitor initiation. And then follow-up occurred from randomization, aka treatment initiation, to 1 year. We used repeated measures models with generalized estimating equations to compare the effects of SGLT2 inhibitor versus DPP4 inhibitor initiation on eGFR slope. And we conducted observational analogs of intention to treat and per protocol analyses. And in addition to the inverse probability of treatment weights, these analyses accounted for missing eGFR observations using multiple imputation, study drug discontinuation, or switching to or adding the comparator drug using censoring. And then we accounted for informative censoring using inverse probability of adherence weights, which were similarly calculated based on factors that might influence adherence. And these were baseline factors as well as time varying factors. So moving on to results. This is a flowchart of our participant selection. 882 individuals with an ADPKD ICD-10 code initiated an SGLT2 inhibitor or a DPP4 inhibitor between January 1st, 2017 and May 1st, 2023. And after applying our exclusion criteria, we were left with 198 DPP4 inhibitor initiators and 217 SGLT2 inhibitor initiators with type 2 diabetes. And these are their baseline characteristics. So their mean age was 67, 93% were male, about 2/3 identified as white, followed by a quarter who identified as Black or African American, less than 10% identified as Hispanic or Latino. The median baseline eGFR at initiation was in the mid-50s for both groups, and we did not have urine albumin creatinine measures on everyone, but its median value was about 50 in each group. And then looking at additional clinical characteristics, we see that the SGLT2 inhibitor initiators had a slightly lower median A1C, and they had a greater proportion of individuals with heart failure or ischemic heart disease or stroke, or who were using diuretics. But otherwise, the two groups were similar, where their mean BMI was 33, more than 90% had hypertension. About 2/3 in each group were using a RAS inhibitor or other diabetes medications, and no one was using tolvaptan. So this slide shows us the results of the intention to treat analysis, where we applied the inverse probability of treatment weights to emulate randomization. So highlighted in purple is the mean change in eGFR per 90 days. And on the right side is a graphical depiction of the change in eGFR. So during the first 3 months after initiation, the SGLT2 inhibitor initiators, represented by the red line, experienced a significant decline in eGFR of 3.14 mils per minute, whereas the DPP4 inhibitor initiators, represented by the blue line, experienced a non-significant rise in eGFR of 0.87 mils per minute. And this amounted to a difference of 4.01 mils per minute per 90 days, where the SGLT2 inhibitor initiators had a steeper decline in eGFR. And this is consistent with the eGFR dip that we've seen in other studies due to SGLT2 inhibitors' hemodynamic effects. During the subsequent 9 months, during the 3 to 12-month post-initiation period, the SGLT2 inhibitor initiators, again, the red line, experienced a non-significant decline in eGFR of 0.11 mils per minute per 90 days, whereas the DPP4 inhibitor initiators experienced a significant decline of 1.56 mils per minute per 90 days. And this amounted to a difference of 1.45 mils per minute per 90 days, where the SGLT2 inhibitor initiators had a more attenuated long-term eGFR decline compared to the DPP4 inhibitor initiators. And now highlighted in purple are the results of the per protocol analysis. So this is where we censored individuals who are non-adherent to their treatment, and then we applied inverse probability of adherence weights to account for informative censoring. And the results were similar. So in the first 3 months after initiation, the SGLT2 inhibitor initiators experienced a 4.03 mils per minute per 90 days steeper decline in eGFR than the DPP4 inhibitor initiators. And then during the subsequent 9 months after that, in the 3 to 12-month post-initiation period, the SGLT2 inhibitor initiators experienced a 1.29 mils per minute per 90 days more attenuated decline in eGFR. compared to the DPP-4 inhibitor initiators. So there are limitations to the study, including generalizability. The cohort was primarily male and white. They also had comorbid diabetes and cardiovascular disease, which is not necessarily the case for every patient with ADPKD. And given their baseline characteristics, they likely had milder ADPKD. Also, no one in the cohort was using tolvaptan. We also relied on ICD-10 codes for diagnosis. We didn't have genetic data or imaging data for more definitive diagnoses. And because we didn't have imaging data, we were also not able to look at the effects of SGLT2 inhibitors on cyst or total kidney volume change. And finally, inverse probability treatment weighting can help account for confounding due to measured variables, but not unmeasured variables. So there is the potential for residual confounding. Some strengths of this study are that, to our knowledge, it's the largest observational study on SGLT2 inhibitor use in ADPKD to date. Using the VHA database allowed us to comprehensively capture the clinical variables. And using the target trial emulation study design along with the intention to treat and per protocol analyses allowed us to account for confounding due to treatment indication and bias that may result from differential adherence. So in conclusion, veterans whose kidney disease is likely driven by mild ADPKD and other comorbidities such as type 2 diabetes may benefit from long-term SGLT2 inhibitor use, at least compared to DPP-4 inhibitor use. But given the limitations that I mentioned before, we do need more studies to look at SGLT2 inhibitors' effects on cyst growth across a wider spectrum of ADPKD disease severity in conjunction with tolvaptan in a more diverse patient population. So thank you for listening. I also want to thank my mentors, Erin, Mian, Michelle, and Mike, and the funding I received from the Ben J. Lips Research Fellowship Grant. These are my references, and I'm happy to take questions if you have time, or afterwards too.
I think we have time for one question if anyone has a burning question to ask at the moment. Great. Oh, go ahead.
Can't have no question. This is outstanding work. It's really hard, especially the data set is not particularly large. You didn't tell us anything about the propensity model. What all went into it? How well did it predict the two treatments? And how well did it balance the observed characteristics? Thank you.
So what it went to, it included socio-demographic, I can't list them all off the top of my head, but it was socio-demographic factors, other comorbidities, some medication use, and also facility characteristics. And I do have the resulting love plot, which showed that the inverse probability of treatment weighting did result in covariate balance between the two treatment groups. You can see that after we applied the inverse probability of treatment weights, there was the standard mean difference between the variables in the two different treatment groups was less than 0.1.
Great. Thank you.
Thank you.
All right. Our next speaker is Ms. Maggie Westemeyer. She is a genetic counselor and currently directs the clinical genetic services and organ health at Natera. During her tenure there, she's helped clinicians and patients understand their genetic test results and the next steps based on those results, and contributed to the development of Natera's expanded carrier screen and renal genetic test. And she'll be presenting her work on Fabry's disease variants amenable to chaperone therapy in a large CKD population. Welcome.
Thank you for having me today. These are our disclosures. And so importantly, as mentioned, I'm an employee and stockholder of Natera. And I hope you'll bear with our slides. This is the first time NKF has done oral poster presentations, and we were asked to keep it to one slide. And so we have 2 slides. So if they're a little busy, that's why. So my objectives today are for you to understand that broad panel genetic kidney disease testing can diagnose Fabry disease in individuals without a prior clinical diagnosis. A molecular diagnosis of Fabry disease can offer critical insights for guiding the use of variant-specific therapeutics, such as Meghana, chaperone therapy, which enables tailored treatment. GLA gene variants amenable to chaperone therapy can cause milder Fabry disease, evidenced by later age at diagnosis and lower clinical suspicion of disease. So I would like to provide some basic background about Fabry disease. Fabry disease is caused by variants or mutations in the alpha-galactosidase A gene, which is located on the X chromosome, and the gene symbol is GLA. So as a result, there's reduced or absent activity of alpha-galactosidase A enzyme, leading to the slow and progressive accumulation of glycolipids in plasma in various tissues in various organ systems throughout the body. The primary substances that accumulate are GL3, GB3, and lyso-GL3 in their deacylated forms. This lysosomal storage disease presents with a wide range of clinical symptoms, with end-stage kidney disease, hypertrophic cardiomyopathy, and cerebrovascular disease being the most severe. Fabry disease is difficult to diagnose clinically due to its rarity, variable symptoms, and overlap with other conditions. Many of its symptoms are nonspecific, and it also affects multiple organ systems. So this makes it easy to misattribute Fabry symptoms to other disorders. Enzymatic testing can be used to diagnose Fabry disease in males, but it's not accurate in females. So GLA testing, genetic testing, is the gold standard for Fabry disease diagnosis. In terms of treatment, since 2001, enzyme replacement therapy using agalsidase alpha or agalsidase beta has been the mainstay of treatment, albeit with limitations such as rapid clearance or immunogenicity. In 2016, a pharmacological chaperone therapy, Meghana, which is an oral medication, was approved for the treatment of Fabry disease. But this treatment is used only for GLA mutations that are amenable to the chaperone therapy. So Meghana binds to the active sites of certain mutant forms of alpha-galactosidase A, thereby stabilizing these mutant forms in the endoplasmic reticulum and facilitating normal trafficking to the lysosomes. And so here I'll show you our research focused on real-world evidence on identifying molecular diagnoses of Fabry disease using broad kidney genetic testing in a large population of patients with CKD. So patients who have renal disease genetic testing may not have a prior clinical diagnosis of Fabry disease to help guide therapy. So we wanted to look at whether patients with GLA variants in our cohort had a pretest diagnosis of Fabry disease, and then also look at which cases were amenable to chaperone therapy and what the characteristics were of those cases. So we screened our large internal database of cases referred for genetic testing, generally on patients with CKD, with a 385 gene panel, the Renocyte test, to identify those with pathogenic and likely pathogenic GLA variants. And available clinical and demographic data included age, ethnicity, sex, and ICD-10 codes. These were assessed. And the identified pathogenic and likely pathogenic GLA variants were compared to the amenable variants reported in the prescribing information for Meghana, which is also available on their website, classified as amenable, non-amenable, or unknown with respect to Meghana use. So out of 67,437 individuals tested, we identified 111 cases who had a pathogenic or likely pathogenic GLA variant. 56 unique variants were present amongst those 111 cases, and more than half of those cases lacked a prior clinical diagnosis of Fabry disease, which was determined by information on the test order form, such as the ICD-10 code or any handwritten information. The patients with the pathogenic and likely pathogenic variants were categorized by Meghana amenability, as shown in Figure 1. So 44% had amenable variants, and about 2/3 of those had no prior Fabry disease diagnosis. And of those, 57% were female. 40% of cases had non-amenable variants, and around half of those had no prior Fabry clinical diagnosis. The remaining 15% of patients had variants of unknown amenability, according to the prescribing information, and then among those, about 2/3 had no prior Fabry diagnosis. So in Figure 2, we looked at the age of the patients with these GLA variants and found that those with amenable variants were significantly older, with a mean age of 56 years, compared with those with non-amenable variants or variants with unknown amenability, with a mean age of 43 years, and that was statistically significant. So some of the limitations of our study are that we don't know for sure if some of the individuals referred for genetic testing who had a Fabry diagnosis were related, so we don't know if there's any bias. And we don't know for sure if a different ICD-10 code was used on the test order, whether that patient did indeed have a prior Fabry diagnosis. So we worked with the information that we had at the time of testing at the laboratory. And in our cohort, in conclusion, 44% of those with a GLA variant were amenable to chaperone therapy. Patients with amenable variants are known to have milder Fabry disease, which may explain the lower rate of pretest Fabry diagnosis in this group. And in conclusion, broad panel kidney disease testing can identify a molecular diagnosis of Fabry disease and enable tailored treatment with chaperone therapy. I'd love to just give one other little statistic that's not included in this, but it's in the same cohort. It was just of note that 10% of patients with the Fabry diagnosis had a second positive genetic finding on their genetic test. So we presented that at ASN last fall, but the same cohort. So thank you.
Thank you. Right, any takers on questions on this presentation? If not, while we're waiting, could you clarify how, and I apologize for my ignorance on this, how amenable and sort of status was determined in the study?
Yeah, so by consulting the Meghana prescribing information, so as part of the approval process for that drug, it had to be proven and again, I am not a pharmacist and this is not my area of expertise, right? But it had to be proven whether these variants were felt to be amenable to therapy or not. And so our role in this was simply consulting, the prescribing information to see if variants identified through our testing are, number one, present in that list, right? So some were not. Mm-hmm. So some were present and marked as unknown by the prescriber. Some were just unknown in general. And then others were amenable or non-amenable.
Thank you.
Yeah.
Any other questions? All right.
Thank you.
Thanks very much. All right, our next speaker is Dr. Wolfgang Winkelmayer. He's the Gordon A. Kane Chair in Nephrology and serves as the chief of the section of nephrology at the Baylor College of Medicine in Houston, Texas. He is a prolific clinical investigator with more than 15 years experience in conducting NIH-funded research focused on the intersection between cardiovascular and kidney health. And today he'll be presenting on Vadadustat for treatment of anemia in older versus younger patients with dialysis-dependent-CKD. Welcome, Dr. Winkelmayer.
Thank you so much, and howdy, Texas. True Texan, right? All right, so here's some disclosures. Let me condense it for you. 3 of the authors are employees of the sponsors. The other 4 people or 3 people served on the academic steering committee of this program, from which I'm honored to present some more detailed results here. So here's the learning objectives. I'm hoping to review the key results of the global INNOVATE trials of Vadadustat versus darbepoetin alpha in patients with anemia associated with dialysis-dependent-CKD. Further evaluate the safety and efficacy in patients specifically that are either older or younger, so aged less than 65 years or 65 years or older. And then finally to discuss the clinical implications for the use of HIF-PHIs, hypoxia-inducible factor, prolyl hydroxylase inhibitors, and I'll say it only once. Specifically in older and in younger patients with anemia associated with CKD. So we'll get you to work. Take your cell phones out. Here's a word cloud coming. In patients with dialysis-dependent CKD, which factors do you consider before initiating treatment with an ESA or with a HIF-PHI? The seconds are ticking. Hemoglobin, iron stores. Excellent. Well, I need to disappoint you. We'll not talk about iron stores in this talk, but we'll have hemoglobin. Blood pressure, huh? So a little bit of background. So Vadadustat, and this is an oral HIF-PHI, and it stimulates endogenous EPO and red blood cell production. And how does it do so? HIF-PHIs mimic the physiological effects of hypoxia by inhibiting PHD proteins. So these prolyl hydroxylases, HIF-alpha gets produced on a very rapid scale, ongoing, and gets broken down very, very quickly, equally fast by these prolyl hydroxylases, and that is when you have normoxic environment. However, if you have hypoxia, the prolyl hydroxylases are no longer breaking down the HIF-alpha, and it can pair up with HIF-beta, and then together lead to a myriad downstream effects on terms of gene transcription. And for the purpose of anemia, it leads to increased endogenous EPO production. It decreases hepcidin levels, and therefore also increases utilization of iron. The INNOVATE study design, just very brief, this was not just one, it was 2 global phase 3 open-label randomized non-inferiority trials that compared the safety and efficacy of Vadadustat with that of darbepoetin alpha in adult patients with anemia. These 2 trials, there was a smaller one in incident dialysis patients, and then there was a larger one, 3,500 patients that were prevalent dialysis patients. There was slight overlap. You know, the first former had to have no more than 16 weeks prior to since dialysis initiation, and the other one couldn't have patients that were on dialysis less than 12 weeks. The coin was flipped, and so patients were randomized to receiving Vadadustat or darbepoetin alpha, the latter in line with the local dose and the local label. There were a number of phases. For efficacy, there was a primary evaluation window after 24 to 36 weeks. There was a secondary evaluation period, weeks 40 to 52. That was with regard to anemia control hemoglobin. But then there was a long-term treatment, starting week 50, actually not starting, but beyond week 53 until the end of treatment where safety was being evaluated. And so the background and objective here today is the primary safety endpoint was time to first adjudicated major adverse cardiovascular event, which was either mortality from any cause, non-fatal MI, non-fatal stroke in patients randomized to one of the 2 treatments. This was a non-inferiority trial, and the pre-specified margin was a hazard ratio of 1.25. And in the overall program, Vadadustat met the non-inferiority criteria for risk of MACE. The hazard ratio was 0.96. The confidence limits were 0.83 and 1.11. The 1.11 safely being lower than the margin of 1.25. So non-inferiority was established compared to darbepoetin. But older patients with kidney failure are more likely to have comorbidities, experience polypharmacy, and be frail compared to younger patients. And also adverse event prevention and management may be particularly important for older patients. And so here the objective is to compare the safety and efficacy of Vadadustat versus that of darbepoetin in patients with anemia associated with dialysis-dependent chronic kidney disease by age at baseline, with the threshold here, the cutoff was 65 years. So again, here the safety endpoints, once again, time to first MACE. I already told you the components here. And there were a number of secondary safety endpoints, which was an expanded MACE, where hospitalizations for heart failure were also included, as well as thromboembolic events, not including vascular access thrombosis. And then all-cause mortality, cardiovascular mortality, as well as a cardiovascular MACE that didn't include non-cardiovascular deaths in its endpoint. And then the efficacy endpoint was the primary and secondary efficacy endpoint in these 2 time windows that I mentioned, the mean change in hemoglobin level from the baseline to these 2 time windows. Let's look at the baseline characteristics here, stratified by age. On the left, less than 65, on the right, 65 years or older. And you can go through this at the leisure of your own time, maybe when you stand in front of the poster later on. But I just want to highlight 2 things. First of all, the between group differences were negligible. The randomization still worked very well, even within the strata of age. But what we speculated and is confirmed here is that comorbidities were more common in patients of older age. You see that there is more heart failure in terms of New York Heart Association class 2 or 3 in the older patients than in the younger patients. There was also more diabetes. There was also more pre-existing cardiovascular disease. Here are the main endpoints here, the major adverse cardiovascular events and the secondary safety endpoints. And what you can see here, just looking at these plots, is that the effect estimates are strikingly similar. The confidence limits are as well. The MACE, that's the first couple of plots here, indicates a hazard ratio of 1 with a confidence limit between 0.81 and 1.23 for younger patients. And for the older patients, it was 0.892, leading from 0.75 to 1.13. I didn't draw the non-inferiority margin here because it has no meaning in the subgroup analysis, but even if you were inclined to do so, both of these age strata were non-inferior compared to that predefined margin of 1.25. And you can see that the results are very consistent across the expanded MACE, all-cause mortality, the cardiovascular MACE, or cardiovascular mortality. Efficacy hemoglobin levels over time. Here you see in red darbepoetin and in black Vadadustat, and the open circles are the older patients, the full ones are the younger patients. And you can see after that titration period early on, where Vadadustat was predefined to be given in a certain dosage for everybody, and in the darbepoetin, the dosage could be selected depending on what was previously given. After the adjustment period in the primary and the secondary evaluation period, those two drugs are near identical in hemoglobin control, and that has been shown for the overall as well as for the subgroup population. What about adverse events? We're talking about that aspect of safety now. Neither in the younger nor in the older patients there was any meaningful difference in treatment-emergent adverse events. In the column of any drug-related TEAE, there are some differences, but you need to remember this was an open-label trial, and it's much more straightforward to attribute a side effects to an unknown treatment than to a known treatment with which you are familiar. So I would like to look a little bit further down and look at any drug-related serious TEAD, and that was strikingly similar between the two groups again. Here are treatment-emergent adverse events. Once again, these are the events that occurred in more than 10% of patients. What you can see here that is that that pneumonia, which was the most common adverse event here, greater than 65 years is here on the right and the younger patients on the left. You can see there was a little bit more pneumonia in the Vadadustat group. There was a little bit more diarrhea, but conversely, there was less hypertension. There was less hyperkalemia. But overall, looking at this in the big picture, really quite comparable safety profile, both for younger and older patients when comparing darbepoetin with Vadadustat. Now we're looking at serious treatment-emergent adverse events of special interest. What does it mean of special interest? These were events that had some basic science prior to going to this trial program, or adverse events that came out through other similar programs that had to be looked at specifically. And what you can see here, just in a very, very brief glance, is that the red columns on the right-hand side, which is the older population, are all further to the right than the blue columns, which means that there's not a single instance for the older patients where Vadadustat had more than darbepoetin in terms of the frequency of these effects of special interest. So in conclusion, in this analysis of the phase 3 INNOVATE trials in patients with anemia and dialysis-dependent chronic kidney disease, the safety and efficacy of Vadadustat were generally similar to that of darbepoetin alpha across the two age strata. The hazard ratio for MACE, the primary endpoint here of safety, was 1 for patients aged less than 65, and it was 0.92 for those patients who were 65 years or older. The confidence limits very similar, none touching the non-inferiority margin. Mean hemoglobin concentration was similar across the treatment groups, irrespective of the age at baseline, and the incidences of any treatment-emergent adverse events were similar across treatment groups, irrespective of age at baseline. I would like to acknowledge the patients, the study investigators, and the site personnel, of course. The study was funded by IQVIA, and Syneos Health provided assistance in putting these slides together. Thank you very much. I stand open for questions.
I'd invite anyone with any questions to come up to the mic. Okay. quiet group this afternoon. I had a backup question, Dr. Winkelmayer. Okay. This is actually more related to the overall study. Did the study evaluate sort of patient-centered outcomes, preference for a pill versus, say, an injection or...
Well, one of them is an oral treatment, the other one is an injectable treatment, but the coin was flipped. So it didn't really evaluate preferences of patients. They got assigned a treatment or the other because of the flip of a fair coin. But it refers to the implications. It provides for the first time, I would say, choice for patients to have an oral treatment and not an injectable treatment. We see right now how this gets rolled out. The drug hit the market just a couple of months ago. So we'll see what the experience will be.
Great.
Hi, I'm Stephen Burke. I'm one of the authors, so I shouldn't be asking a question, but you know a lot more about statistics than I do. Because age above or below 65 was a stratification factor as part of the randomization, is it true that it means that the comparison within the strata is randomized, or do you lose some of the, it's pre-specified, it's a stratification factor. What does that make it?
Well, it ensured that age was balanced between the two groups. And I think there was a key learning from the EVOLVE trial that did not have age at baseline balance between the two groups. And so it really ensured that these characteristics are also balanced on average within the strata of age. But otherwise, I don't think it has any additional or lesser meaning than just a subgroup analysis of a large trial. We didn't test for heterogeneity with regard to the outcomes. We didn't do any tests for interaction formally. But I think everybody can see what the plot renders and make their own conclusions. And my personal conclusion is, that there's really no major difference to be glanced from this.
Thank you, Dr. Winkelmayer. All right. Our next speaker is Dr. Benjamin Brier. Dr. Brier is a lieutenant in the United States Navy and is a first-year fellow of the National Capital Consortium Nephrology Fellowship located at Walter Reed National Military Medical Center in Bethesda, Maryland. And he'll be presenting on chronic kidney disease testing among diabetes patients in the U.S. military health system. Welcome, Dr. Brier.
All right. Thank you and good afternoon. As you just mentioned, my name is Ben Brier, and I am a first-year nephrology fellow at Walter Reed. I greatly appreciate this opportunity to present our data on CKD testing among patients with diabetes in the military health system. This is our disclaimer and our disclosures. So the learning objectives for this presentation are to, 1, indicate annual CKD testing rates among patients with diabetes in the U.S. general population. 2, indicate annual CKD testing rates among adults with diabetes in the military health system. And then 3, assess how the study findings may impact overall strategies on CKD testing in patients with diabetes. So, despite guideline recommendations, annual CKD testing for both UACR and GFR remain low, depending on the study that you look at. It's between 25 and 50% among adults with diabetes in the United States. As an integrated healthcare system with universal coverage, we hypothesized that CKD testing rates among adults with diabetes in the military health system would be higher than the overall national trend. And so to look at this hypothesis, we used the military health system data repository and analyzed the annual prevalence of patients with diabetes with and without CKD from 2016 to 2022 who were tested for both GFR and urine protein excretion. We looked at urine protein excretion and not just UACR. We used a composite of UACR, urine albumin, urine protein, and urine protein creatinine ratio. And then after looking at the prevalence, we conducted a logistic regression analysis to assess association of demographic factors and dual lab testing, adjusting for rank, active duty status, and other comorbidities. Our study population consisted of individuals with at least one inpatient or two outpatient encounters in a given year in the military health system. And patients were greater than 18 years of age, or 18 or greater adults. CKD was defined by ICD-10 codes, and we included both type 1 and type 2 patients with type 1 and type 2 diabetes. We excluded pregnant females because of the physiologic increase in GFR and proteinuria during normal gestation. We also excluded patients with end-stage kidney disease, defined as a requirement for dialysis or having a kidney transplant. To define our diabetic cohort, we used patients that had an ICD-10 code for diabetes, plus either an outpatient prescription for diabetic medication or medication for diabetes, or an A1C greater than 6.5%, or a random outpatient serum glucose of 200 milligrams per deciliter. And so defining our diabetes our cohort this way, we identified 165,000 individuals with diabetes in 2022 out of the entire study population. That was 6.5% of the total study population. The median age of the diabetic cohort was 60 years. 51% were male. Almost all were non-active duty beneficiaries in the military health system. The median eGFR was 78 milliliters per minute. The median UACR was 22 milligrams per gram, and the median UPCR was 0.32 grams per gram for when the data was available. So this is what we intended to find. So the diabetes cohort in 2022 had urine protein testing for 64% of the patients that were identified. And then eGFR testing was present for 87% of patients. And co-testing, the presence of both tests, were present in 62.5% of patients. So we did this over, I gave you that breakdown for 2022, but it was done over from 2016 to 2022. And this figure shows the annual prevalence of dual testing in patients with diabetes and the MHS over those years. And you can see that the prevalence is greater than 60% over the years and was slightly lower in 2020 during the COVID pandemic. This figure shows the annual prevalence of dual testing in patients with diabetes by their CKD status. So the blue bar indicates patients with diabetes that have CKD by ICD-10 code, and the orange bar demonstrates patients without CKD. So it is the data on the previous slide. And you can see that the prevalence of dual testing is higher in patients with CKD and diabetes. And so here, I'd like to highlight some findings from a fully adjusted model that included age, sex, race, rank, active duty status, and comorbid conditions. For clarity, we're only including age, sex, and race groups on this forest plot. Older patients were more likely to be tested compared to younger reference group. The reference group were patients from 18 to 30, and you can see on the right favoring dual testing patients in the age group 65 to 84, and patients age 85 and greater were tested more frequently. Men were less likely to be dual tested than women, and then patients that self-reported as being Asian, Pacific Islander, Black, and self-reported race other were more likely to be tested than a white self-reported race reference group. In this figure, we're showing the percentage of all urine protein labs ordered in the MHS fiscal year 2022 by the specialty of the provider that ordered the test. And you can see that most urine protein testing is ordered by primary care doctors. It's the orange part of the pie, is 55%. Much more than nephrology, cardiology, and other, which represented any other specialty, emergency medicine, rheumatology, infectious disease, other surgery specialties. In this figure, we're showing a similar thing for eGFR. It's the total percentage of GFR labs ordered in the fiscal year 2022 by the specialty of the ordering provider. And once again, primary care doctors or providers are ordering most eGFR labs. So to put our data into context, this is a table that summarizes estimates of dual testing for CKD in patients with diabetes in other large database studies, and it shows that the prevalence of dual testing is 25 to 50%. The second line here is dual testing in the VA is 47%, and so what we saw is that testing is favorable in the NHS at 60%. So while so dual testing is favorable for patients with CKD, testing for CKD in patients with diabetes in the military health system, and we think that this might be related to several strengths of the military health system. First, it is a centralized and integrated healthcare system that fosters multidisciplinary and team-based care. Second, it has a global integrated electronic health record system that improves care coordination among providers and enhances patient engagement in their healthcare. Third, it provides comprehensive and universal coverage with minimal out-of-pocket expenses in both when patients get their care at military treatment facilities, but also when patients get their care in the private sector. And then four, it has the critical mission of ensuring that U.S. military personnel are healthy, and this translates to a strong focus on health promotion and prevention among its beneficiaries. However, testing for kidney health in the military health system diabetes population remains suboptimal. 60% is not 100%. Our data also underscore that primary care doctors are doing most of the testing, and any interventions should be aimed at the primary care setting. So about the military health system data repository and its limitations and strengths. There are limitations of the database in that it's an administrative claims database and the data are not clinically granular. Also, the lab results are not available from the private sector. So only lab claims are available when patients receive care in the private sector. And a strength that I do want to mention is that the demographic, educational, vocational diversity of the military health system population is generalizable to the average American individual for the patients that are under age 65. So in conclusion, CKD testing rates among adults with diabetes in the military health system compare favorably to other national level data. However, our results highlight the need to substantially improve early CKD detection, particularly in the primary care setting, as this is the initial critical step towards effective guideline-directed therapies. In the future, our work will include analyzing dual testing with urine albumin instead of the composite outcome that I mentioned. And then we also want to look not just at patients with diabetes, but for dual testing for patients just with hypertension or cardiovascular disease. I'd like to acknowledge Dr. Nee as my research mentor and acknowledge important contributions from Dr. Oliver, Dr. Kelmus, and Ms. Marnowick, and our entire team. And I'd like to thank the CDC for their support and funding of this project. And here are my references, and I'm available for questions.
Great. Thank you, Dr. Brier.
Monika Niewczas, Jocelyn, fantastic data and a very important topic. Could you speak to the CKD stages breakdown for those measurements where you had about 20% of your population where you had the measurements of the GFR with absent albuminuria? So, for example, if you have a lot of people with GFR below 60, that really would be a call for action. So could you speak to this particular subpopulation?
I don't think I have it broken down by GFR.
Because when you were showing, there were about 80% of the people who had GFR measured and 62 people who had albuminuria measured, and dual testing was about 63, which means everyone who had albuminuria measured had dual testing, and there was about 20% who had GFR only. So I was just wondering, what's the GFR breakdown in this population? Because you would...
The discrepancy.
Exactly, yeah. So like you have about 20% of people where you have only eGFR. I was wondering what's the breakdown of the CKD stages in this particular population? Because if they are low, that would be really concerning.
Yes. I don't know the answer to that question. But you're right. If they have a GFR less than 60 and they're not being tested, that's a separate issue. Yeah.
Thank you so much.
Yeah.
Dr. Brier, can I ask you one more question? Within the VA, similar to the military health system, we have an integrated healthcare system with coverage for pretty much all the testing, but the data that you presented looks like the VA is underperforming compared to the military health service. Could you talk about, what the practice differences may be in the military health service that has given you positive results?
So I can't say for certain what the difference is, but I do think there is something important about the fact that it is a readiness. The primary goal of the MHS is to be a readiness for a system. So it is a prevention, and that is our primary goal. I think that's a component of it.
Yeah.
It may be different than the VA.
Yeah.
Yeah.
Prevention versus
yes, exactly.
treatment. Got it. Thank you. While we're working on this, I'll present our next speaker. It's Dr. Monika Niewczas. She's currently a principal investigator in the section on genetics and epidemiology at the Joslin Diabetes Center, is an assistant professor at Harvard Medical School in Boston. Her laboratory uses hypothesis-driven and unsupervised molecular approaches, such as proteomics or metabolomics, together with advanced clinical epidemiological tools to search for potential determinants of the progression of diabetic complications.
Thank you so much for your patience, and thank you, Chairman and organizers, for inviting us here and selecting our abstract for presentation. And since this is also the last talk of the session, I apologize for not wearing anything orange, but I do support NKF, and you will see a lot of orange font in our slides. So today I will talk about our findings about urinary complement and kidney function decline into African American cohorts at increased kidney risks. These are my disclosures. There is nothing really substantial related to my presentation. Albumin remains the most established and the only protein in diabetic kidney disease. It is incredibly important, and we know we should even measure this more often. It is nationally recognized by agencies such as ADA or NKF. Nevertheless, we are now in the era of omics. We can measure hundreds or thousands of proteins, so it is plausible to assume that there are more proteins that play a role in the progression of the disease. And importantly, the protein testing capacity has exponentially increased over the last decade or so, and we and others have exercised applying biofluid proteomics to prospective studies to look at the determinants of the diabetic or chronic kidney disease. Our most recent study, which serves as a background for this presentation, will be published soon and leveraged 4 cohorts of subjects with type 1 or type 2 diabetes with advanced or early stages of kidney disease who were followed for up to 10 years for kidney failure. We performed urinary proteomics. Not to brag, this is the very first urinary proteomics using the Aptamer technologies in any chronic prospective disease, and we have identified a very strong enrichment for the complement protein. The discrimination of the risk was substantial, and we performed a very granular evaluation of the entire complement system and identified the top 5% proteins that are listed on the needle plot. Nevertheless, all those subjects were predominantly Caucasians. Therefore, the aim of this study was to evaluate whether associations of complement proteins in the urine are associated with the prospective kidney outcomes in 2 cohorts of African Americans at increased kidney risks. The first cohort was leveraged the diabetes heart study that included African American subjects with type 2 diabetes. And our second cohort leveraged the natural history of APOL1 associated nephropathy and included subjects who were first-degree relatives of American Africans with non-diabetic kidney failure related to APOL1. Those 2 cohorts were established by Dr. Friedman, and we very much cherish this collaboration. And I will not dwell more on the background on how important diabetic kidney disease is. We have heard from Sylvia Rosas and others at 2 p.m., as well as from Dr. Martin Polak and others at the session at noontime. In our study, we included subjects with relatively well-preserved renal function. In other words, they had to have GFR 30 or more, and with subjects who had at least moderately increased albuminuria, so with ACR 30 or more, or A2, A3 plus albuminuria. Otherwise, there were no much surprises in terms of the clinical characteristics, and 1/3 or more of this study population developed moderate or even more rapid renal function loss. Here, these are the main results of our study. Here, the effect estimate represents 1 tertile change of urinary creatinine-adjusted protein associations with the continuous slope. So, for example, in African American subjects with diabetes, we observed that 1 tertile change of the urinary C2 was associated with a clinically meaningful acceleration of the GFR slope by almost 2 ml per year. Overall, we have observed risk patterns for each of the proteins studied, although not all of them reached the statistical significance. Some of the confidence intervals were quite broad, but this is a relatively small population. On the right-hand side, you see the study which I just introduced, based on almost 1,000 subjects followed for 5,000 person years, where we included subjects with type 1, type 2, advanced DKD, or early to moderate DKD. So we can also appreciate that some of the associations, particularly in the APOL1 cohort, are almost as strong as in the advanced DKD. And here we also, in this particular study, we have performed targeted measurements because this is an extension or validation studies. And what we find intriguing is that absolute concentrations of some of those proteins are quite different in comparison with the Caucasian populations. And for example, when we look at the C2 and we see our 2 cohorts, DHS and the APOL1, the absolute levels in those cohorts are close to the top 1/3 of the concentrations in advanced DKD. So they do not correspond as much. They are 3 times higher than matching phenotype in the Caucasians. And the pattern across proteins is interesting, and likely the complement engagement in this particular population exists, but may not be exactly the same as what we see in the former cohorts. And here, arriving at the conclusion, yes, it's just after 5 o'clock, so I would argue that albumin is no longer the only protein of diabetic kidney disease, as we have demonstrated strong associations between complement and kidney outcomes in subjects with diabetes of Caucasian ancestry, African American ancestry, and also now expanding to non-diabetic kidney disease. And based on those findings, we feel that the deep profiling of the complement is warranted. I would like to thank my group, and I have two members of my laboratory sitting in the audience, and those marked in the red fonts are those that were directly involved in the study, as well as very much I would like to acknowledge Dr. Barry Fredman and his professor-level associates, Dr. Palmer and Ma, with whom we work together. On the right-hand side are acknowledgements for all who are involved in the complement study in the Caucasians. And I'm happy to take questions. Thank you so much.
All right. I have actually one question, and it may be that the study may be underpowered, but I was wondering if you took a peek at whether there was any evidence of effect, modification, or interaction between the complement levels and APOL1 risk status.
Yes, so the study is still ongoing, and because you are right, we may not be underpowered, but we do see data that suggests an effect modification or interaction. For example, when we look at the correlation plots between the complement and the slope in the subpopulation with the two risk alleles, it's much stronger than the ones that have 0 or 1. We didn't do all the formal testing yet, but definitely there seemed to be a pattern, and building upon that, there are actually basic science data showing that APOL1 forms complexes with some of the complement proteins that are also of interest, so there may be even biological justification on that. I was quite quiet because then we would need to focus on, we have only 30 people and we are always trying to be conservative, but there seemed to be a promise that there may be more to the story.
Great, great. All right. Thank you very much, everyone, for sticking with us. This is a great session.